Welcome everyone to the 2026 Pulmonology Professional Community Town Hall. It's so great to have you all here with us today. I think we've got a good lineup for you all, and I'll kind of switch over here to the agenda for today's meeting. So we certainly want to start by welcoming everyone to the professional community in the town hall, which the goal of this town hall is really a couple of things. One, to provide an update on some of the activities of the professional community over the last year, to kind of talk about some of the membership statistics and things like that. I'll introduce you to the current committee and also kind of what the committee will look like for the next year. We'll talk about some things that are going to be asked of the committee and of the professional community over the coming year as it relates to the annual meeting and planning for the 2027 meeting, standards and guidelines, and webinars. And then the second half of the talk or of the town hall, we're pleased to have a guest presenter, Dr. Andrew Fisher from Newcastle, who will introduce right before his presentation. And we're thrilled to have him here to share some information on extracorporeal photopheresis. So first, I'd like to start by just introducing everyone to the current committee. My name is Brian Keller. I've had the pleasure of serving as the chair of the committee for the last year, and I also serve as the representative to the Advanced Lung Failure and Transplant Interdisciplinary Network Steering Committee and the Leadership Advisory Forum. We also have online Carly Lear. Carly, would you like to introduce yourself and your role?
Sure. Thanks, Brian. Hi, I'm Carly Lair. I'm a member of the council as well, and I represent our council to the ALF-TX IDN.
All right. And then Lorenzo, do you want to introduce yourself?
Yeah, I'm Lorenzo Zafiri. I'm representative of the Early Career and Trainee Committee, and I've been here for a couple of years in this community.
Wonderful. I don't know if Colin was able to join. Colin Church is also a member of the committee. He's the representative to the Pulmonary Vascular Disease Interdisciplinary Network, and he is based in Glasgow in the UK. And then our final member of the committee is Aida Venado. She's unable to make it to the meeting today as she's on clinical service, and she serves as a representative to ISHLT in Espanol, and she's based out of University of California at San Francisco. On the committee, I will be rotating off the committee this year, and a new member will be appointed by the board, I believe, to replace my position as representative to the Leadership Advisory Forum. Let's see. So in looking at our makeup of ISHLT and of the ISHLT across the board, as you can see, pulmonology makes up about 14% of the society, with cardiology, cardiac surgery making up approximately 50% of the entire society. But I will say it's been very nice to see that our community, as you will see on subsequent slides, has been a very, very active professional community in ISHLT. And I think that is just a testament to the interest and the engagement from our community across all members. Looking a little bit more in detail at the makeup of ISHLT, approximately 2/3 of the membership is made up of physicians. 23% are non-physicians, and importantly, 15% are classified in the trainee category with it, which I think is fantastic and is something we certainly want to continue to encourage and look for ways to engage more and more of our trainee and young career faculty members. In terms of the regions, 3/4 of the members of ISHLT come from North America, with 15% from Europe, and then smaller percentages from other parts of the world. As you can see, about 5% come from Asia and 3% from Oceania. And we are expecting that to increase as ISHLT will be hosting its annual meeting in Australia in 2027. So we're really looking forward to connecting more with that part of the world. And then in terms of the interdisciplinary networks, the Advanced Heart Failure IDN encompasses about half of the ISHLT membership. Lung failure and transplant makes up 26%, so 1/4 of it. And then mechanical circulatory support, pulmonary vascular disease, and other make up the other 25% or so. So for 14% of the membership being pulmonologists, 26% are associated with the advanced lung failure IDN. A couple of things that I'd like to just point out for the upcoming meeting in Toronto. So we're really excited for the annual meeting in Toronto, which will be hosted there from April 22nd to April 25th, with an important pre-conference day on April 21st. So as you can see here, a couple of important dates. The annual meeting, professional community receptions, will be held from 5:30 to 6:30 Eastern. The Pulmonology Professional Communities reception will be on Thursday, April 23rd. And then IDN meetings are going to be hosted at 7 a.m. The IDN meetings this year are going to be a little different than in past years. And so you can see here at the bottom, on Thursday morning, the lung failure and transplant IDN meeting will be hosted Thursday morning. The program agenda has been published for the annual meeting, and I think it's really exciting. And one of the things that is always an important part of this are the pre-conference workshops. This year, there are 5 different pre-conference workshops. There's one on advanced cardiac therapies and congenital heart disease. There is a hands-on experience in the ISHLT thoracic recovery course, cardiogenic shock academy. For our trainees, there is an ISHLT training workshop, which I think will be really, really well attended. And then there's a multidisciplinary pre-conference workshop hosted by the infectious disease and pharmacy groups titled From Pathogens to Pharmacokinetics, Optimizing Outcomes in Thoracic Transplant. So if you haven't signed up for these, hopefully there's still time, but I think these will be really well attended and just add to the kind of the experience of those attending the conference in general. As I mentioned, the conference agenda is also out, so please start looking ahead to that and identifying, those sessions that you want to attend. Other things are to start looking at hotel and securing hotel reservations because those can fill up rather quickly. So with that, I'm going to hand over to Carly, and Carly's going to talk about some of the activities of the past year, and I'll cycle through the slides, Carly, as you need me to.
Great. Thanks, Brian. So first, I wanted to highlight the professional community webinars. In 2025, we talked about in June, out with the old, in with the new strategies to increase lung transplantation. This was a great topic. We looked at talking about underutilization of organs, the donor organ shortage, and strategies to improve these options. We then looked at navigating the complexities of lung transplantation and connective tissue disease-associated ILD. And this was a great topic with a lot of clinical highlights for us about how to manage this complex population of patients. And this occurred just this last January, a few weeks back. Next slide. Okay, so these were the 2. Brian, we have 2 of these each year, correct?
Up
I
to,
think you.
yeah.
Sorry,
Yeah.
coming off of mute. So every PC is required to have 1, but we actually had 2 this past year, and this is just showing the registration as well as the attendance and YouTube views.
Great. Yeah. So we had 85 registrants for our June one and over 200 YouTube views. In our second one, we had 74 registrants and just happened a couple weeks back, so fewer YouTube views. Next slide. So as you know, as soon as we start thinking about the current ISHLT, we want to think about what symposiums are kind of brewing in everyone's mind, especially as you're looking at the content of this year's ISHLT. The next year's conference, as Brian mentioned, will be in Sydney with dates from the 14th to 17th of April. Stay tuned for when our symposium proposal dates will be. But I think one of the things that we see as members of the Pulmonary Council are that these, the submissions that we can submit for lung-specific content are really strengthened when members of our council are really engaged here, because just as we are, we're just a few people, but when we use our numbers of lung folks in the ISHLT, we start to see more lung content, I think, as we've seen over the past couple of years. Next slide. Brian, did this one have an advance? Did you have it on the right? I
Are you
thought
able
you'd
to
had
see?
one of the improv. Oh, maybe the slide
Yeah.
changed over.
Yeah, sorry. There was an update with a few more of the topics in progress. So these are all the ones in progress. Oops.
Perfect. Okay, I'll go back and talk about it. Sorry, I just want to make sure I wasn't talking about it midway through. So recently published that I think folks have seen is the consensus statement on short telomere syndrome and lung transplantation. There's also a really great podcast on this that I'd encourage you all to listen to. The consensus statement on the perioperative use of ECLS in lung transplant was published in 2026. Considerations for endpoints in lung transplant clinical trials. This was published in December. And then the consensus statement on referral and selection of pediatric lung transplant candidates was in October. So we've been really active on this front, and in progress, we have a lot of really exciting proposals, including one where we're focused on donor lung, the ISHLT consensus statement on donor lung transplantation, advancing preservation and DCD utilization. One that is really near and dear to my heart is the malignancy in lung transplant, both in the pre-transplant setting and post-transplant setting. One focused on donor and recipient size matching in lung transplantation. There's an update on the report for the ISHLT working group on PGD. There's a 2025 in progress, one on the working classification of lung allograft pathology, one on addressing frailty in lung transplant candidates, baseline lung allograft dysfunction, both the definition and timing, as well as implications for outcomes. The AMR document and proposed graft antibody and pathology, the gap definition, and then finally the consensus statement on ALAD, definition, diagnosis, and therapeutic approaches, which I believe is coming out very soon.
We will have time at the end after Dr. Fisher's presentation for comments and questions, as well as maybe some brainstorming. And at this point, I would like to hand things over to Lorenzo, who's going to introduce our speaker, and then also kind of moderate the discussion at the end of the town hall. So, Lorenzo.
Thank you, Brian. Hi, it's my honor to introduce Andrew Fisher. He's a tenured professor of respiratory transplant medicine at Newcastle University and transplant pulmonologist at the Institute of Transplantation, Freeman Hospital in Newcastle upon Tyne in UK. He's the co-director of the NIHR Blood and Transplant Research Unit in organ donation and transplantation. His clinical and research interests are in advanced severe lung disease and lung transplantation. He leads a research group focused on understanding the mechanism of lung injury and repair, including before and after lung transplantation. He has published extensively in the field and is including co-authoring invited review of lung transplantation recently on the New England Journal of Medicine in 2024 with Jason Christie. He is the UK National Clinical Lead for the EVLP and is overseeing the launch of a pilot national EVLP service to serve all the UK lung transplant center as part of the new NHS Organ Assessment and Recovery Center program. He has served as ISHLT in numerous roles, including program chair in 2016, president of ISHLT in 2017, and chair of the Publication Oversight Committee in between 2020 and 2024. He also oversaw the recruitment of the new EIC for GHLT and the launch of the GHLT Open. So it's my pleasure to introduce Andrew Fisher to talk about EVLP. And
thank you very much indeed. Can you hear me okay?
we can hear you, yes.
Perfect. So I'll just share my screen. Can you see the slides?
Yes.
Yes.
Perfect. Well, thank you very much indeed. It's a real pleasure to be here with the team, and thank you for the invitation. I've been asked to talk about personalized immunosuppression, and I've titled it "Where Are We?" And I'm going to focus predominantly on ECP later in the talk, but we're going to start with a little bit more of a general view on the topic of personalized immunosuppression. I have a few relevant disclosures, which are shown on the slide here, some research and speaker fee associations with Theracos, and I'm the chief investigator for the UK national trial in ECP. So let's start by thinking about what personalized immunosuppression means. And it's actually an approach which allows us to tailor the type and dose of immunosuppression to an individual's unique biology and clinical profile. And it's often talked about as trying to target the Goldilocks zone. So just the right amount, not too much, not too little. So essentially we want to maximize the efficacy of the immune suppression effects while also minimizing the toxicity and the adverse events that are associated with immunosuppression use. And that in itself should lead to an improvement in quality of life and tolerability of the immunosuppression. This audience will be very familiar with the constant balancing act we have when we're using immunosuppression to manage our lung transplant recipients. If we get the balance wrong, if we overdo it on immunosuppression, we risk increased infection, PTLD, cardiovascular risks, renal dysfunction, malignancy. And if we don't get it right, if we don't give enough, we risk rejection, acute rejection, CLAD, the need for retransplantation, and of course, mortality. And at the moment, the main tool we have to guide us is therapeutic drug monitoring. And as you can see from the graph here, we're talking about trying to achieve a steady state based on an individual dose that the patient's been exposed to. The problem is that therapeutic drug monitoring comes with some significant limitations. First of all, it's only available for certain agents we use, mainly the CNIs, certainly in terms of widespread availability. Second, it's helpful in identifying whether we've reached a predefined target drug concentration, and therefore helpful in identifying potential drug toxicity when levels are too high. We don't know, however, whether the trough or the peak levels are the best representation of exposure to the immunosuppression and how that particularly impacts on the outcomes. And although we measure serum concentrations, it could be that the intracellular concentrations of the drug are actually a much better representation of its immunosuppressive effects. But the most important is a drug concentration does not tell you the impact that drug is having on that patient's immune system. And therefore, it's unhelpful in really assessing the efficacy of immunosuppression. And the consequences mean that we tend to use immunosuppression regimens and drug target levels as standardized approaches across recipients by organ or by center. And also, we tend to change the dosing based on the presence of side effects and also in a striving to achieve a particular drug concentration. This takes no regard for interpatient pharmacodynamics, and it leaves many recipients over-treated, over-immunosuppressed, and many under-immunosuppressed, and probably very few that are just right. And therefore, it does not provide personalized immunosuppression. And we end up with this situation where one size actually fits none. So if we look at the current approach, we design a regimen. It may be an organ-specific regimen, it may be a center-specific regimen, and we expose the recipient to that. We use therapeutic drug monitoring to look at the immunosuppression levels, and we feed that back into the regimen. We can monitor for immunosuppression side effects, and again, we can feed that into the regimen and the dosing. And we also monitor graft function using the techniques like you see on the right side of the slide. However, we need to move away from this approach on its own and add in some additional approaches to actually monitor the immune response and better understand how immunosuppression is affecting the way the immune system is working, and particularly how it's impacting on the graft. So if we monitor immune response, we can understand whether we're under immunosuppressing, and there may be evidence of ongoing allograft injury. If we're over immunosuppressing, we may be able to detect things like latent virus activation and understand that we're giving too much immunosuppression, and both of those could then feed into the dosing regime for the immunosuppressant regimen. And that will allow us to try and achieve this equilibrium between under and over immunosuppression. Furthermore, we should now be starting to collect patient-reported outcomes and experiences as to how they're managing with their immunosuppression regimes, and also feeding that back into how we decide which regimens to use. Recently, colleagues and I did a detailed review of the molecular monitoring tools that were available to monitor lung allograft health. And we asked ourselves, are these ready for routine clinical use? And there are a number of different candidate molecular monitoring approaches, and I've listed them here on the slide. The ones in bold are the ones that are perhaps sort of commercially available and in to some degree use across the world. There are, however, several other markers which are growing in interest as more data emerges. If we look at the journey the organ takes from the time of transplantation and hopefully with a long-term survival, but eventually graft failure, then the molecular monitoring approaches have a place in different parts of that pathway. At the time of graft health, then I think we have some reasonable data, which I don't have time to go into in any detail at all, but donor-derived cell-free DNA is a useful way of showing stable graft function and an absence of graft injury. So there is some good evidence to support that. If we look at ALAD, however, we can break that down further into infection, into antibody-mediated rejection, and into acute cellular rejection. And in those cases, there's a range of different markers that have been identified and investigated with some evidence base. Infection includes, obviously, over-immunosuppression leading to increase in torctinovirus load, an increase, a surge in donor-derived cell-free DNA can happen with infection, and also interest with exosomes as markers of cell-to-cell communication. In antibody-mediated rejection, there is evidence of increases in donor-derived cell-free DNA, and again, the same in acute cellular rejection. But there is also growing evidence of the load of information that can come from things like molecular microscopy and tissue transcriptomics, circulating microRNAs, and again, exosomes. And then finally, with chronic lung allograft dysfunction, again, a range of different approaches, including in this time markers of methylation as part of epigenetic modifications that can be detected. However, really, we're some way from applying these into practice. And we need to think about the future and how we need to generate the evidence that these tools are making a difference in how we could manage the care of patients who've undergone lung transplantation. So we urgently need proper randomized controlled trials that compare the current standard of care with pathways that have been augmented by one or more of these molecular diagnostics. We need those trials to have very clearly defined primary outcomes, such as either rejection rate, use or lack of need for invasive testing, and also long-term graft function. And we also need real-world data collected. It could be by clinical databases, registries, or even insurance data, which is prospectively designed to generate real-world evidence of the impact of these molecular diagnostic approaches. Unfortunately, we're surrounded by often retrospective, single-center studies that have not been designed in a randomized way to actually truly measure the impact of these. So multi-center and ideally international and longitudinal rather than cross-sectional approaches, which then should be sufficiently powered as what's needed. I would also warrant that we need to look at these diagnostics probably in combination rather than alone, or starting alone but adding in combination approaches. It's unlikely that one single marker itself will give us all the answers considering the complexity that we face in the lung transplant patient's pathology. And also, very importantly, we should be using these tools to help us understand immunosuppression, personalization, and minimization. And this should include secondary outcomes such as renal function, infection rates, diabetes, and patient-reported outcomes of the side effects of immunosuppression. Of course, the aim is to minimize immunosuppression while also protecting the graft, and we need to capture the evidence that that is occurring. So, and the final part should be that we need to look at the cost effectiveness of these approaches to make sure that they represent value for money for the charges associated with using it. So I'm going to move on now to the second part of the talk, and that's to focus a bit more on an intervention which may have a place in guiding a personalized immunosuppression approach. And that's a treatment called extracorporeal photopheresis. I co-authored a review of this and its place in solid organ transplantation just last year in the American Journal of Transplantation. And what the treatment is involving, for those that aren't familiar with it, is sometimes it's called dialysis for the immune system. Essentially, the patient undergoes removal of about 10% of their circulating blood volume. In the enclosed system, which I'm going to talk about, it goes directly into the ECP system. The blood is centrifuged. A buffer coat containing the leukocytes is separated. The red blood cells are immediately returned to the patient, but the leukocytes are collected and exposed to the drug Uvadex or methoxylin, and then that methoxylin is activated by exposing those treated leukocytes to ultraviolet light UVA. Those treated leukocytes are then returned back to the patient, where over the next few days, the therapeutic effect will be elicited. So what are the potential roles for ECP in lung transplantation? Well, there's a number of reports, again, usually single center, that have suggested that, for example, it may have a role in induction therapy to minimize rejection risk, in which case it's being given as a prophylaxis against rejection. It may have a treatment as treating recurrent acute rejection episodes in patients who experience rejection despite their optimal use of immunosuppression. And it also has a role in potentially minimizing immunosuppression in a number of different circumstances. For example, patients who have resistant or relapsing, difficult to treat infections can have significant immunosuppression minimization and ECP to help protect them from rejection. Patients with challenging PTLD that doesn't respond to simple immunosuppression minimization or is resistant to that, again, ECP could be used to augment their treatment while minimizing immunosuppression. And then there's a couple of rare scenarios which are well recognized in lung transplantation where ECP has been shown to have a role. One is HLH, and the other is the graft versus host phenomenon that's sometimes seen in solid organ transplantation, including after lung transplantation. However, the final one is in chronic lung allograft dysfunction, and that's been my major interest over the last few years. I don't really need to educate this group on what CLAD is or the importance of CLAD and its impact on the well-being of our patient population. We'll recognize that CLAD has different levels of severity. We'll recognize that there are two broad phenotypes, although there's a substantial group that sit in that mixed phenotype as well. And we'll recognize that we don't have a clear and highly proven effective treatment available either.
Yeah. And then I have to have a call with you because I am working on the social listening, and it's kind of come full circle. I had a call with Aaron earlier today.
Oh, good.
Hi.
Sorry. Someone forgot their mute. So if we go back, the experience in using ECP to treat CLAD has been around for a long time. And this was a seminal study published by the group in Vienna, who've been at the forefront of the utilization of ECP in lung transplantation, published in 2012. And this was the first that really showed that in a significant population of patients, 51 patients with BOS treated with ECP and a 61% response rate. And you can see here that the ECP responders had a better long-term survival than those who did not receive any ECP. And then the ECP responders had a better outcome than patients who got ECP who were non-responders. So this was very encouraging. And it was perhaps the first of quite a number of studies that have been published in this nice review from Ramsey and colleagues back in 2018, reviewed the number of single center studies that have been published, again, showing similar findings of a group who were responding to treatment and were getting some benefit from the use of ECP to treat, in most cases, BOS. Most of the studies were focused on loss of lung function and looked at the slope of the loss of the FEV1 before and after the instigation of ECP. And some of the studies looked at survival as an outcome as well in longer term. However, the problem is that every study published was single center. None of them had a control group. There was clearly biased patient selection because they were not continuously recruited, and there were no patient-reported outcomes and no exercise-related outcomes such as function or ability to manage, say, a 6-minute walk test. More recently, the team in Vienna teamed up with several other large European centers to combine their experience, and they reported the outcomes for 630 patients who'd undergone ECP. This increased the power of their findings, but again was based over a 22-year period across multiple time points where other therapies also changed. no control group. But they did again show what has been picked up, that perhaps the RAS phenotype is less responsive, and the earlier you start ECP after the onset of CLAD, then the better the outcome for patients who are receiving it. We have, however, had our first ever randomized controlled trial investigating the use of ECP in lung transplantation. And again, this came from the Vienna group, who did a very nice study randomizing patients at the time immediately post-transplant. So this is the induction approach that I mentioned earlier, to see whether they could prevent acute rejection. And they showed a significant reduction in acute rejection episodes of grade 2 or higher in the ECP-treated patients. And when they followed these patients for 3 years, and again, the freedom from CLAD was also better in the ECP-treated group. So again, the first ever evidence of, in an RCT, of an effect of ECP, but this was prophylactic treatment. So in the UK, we were struggling to get access to ECP to treat our patients with CLAD. The NHS is quite careful in how it resources treatments, and it expects to have evidence available. And we told the quality of the evidence was not good enough. And that's why the UK transplant community came together and worked to seek and secure funding to run our own randomized controlled trial. And this is how the ECLAD UK trial came about. Its primary objective really is to see whether ECP plus standard of care is more effective at improving or stabilizing lung function in patients with CLAD compared to standard of care alone. And the primary outcome measure is a composite responder outcome defined as both stabilization of lung function from baseline to 24 weeks and an absence of no rapid decline over the initial 12 weeks from baseline. And stabilization was defined as both FEV1 and FVC declining by less than 10% or improving over the 24 weeks of treatment, and rapid decline was defined as a greater than 20% fall over the initial 12 weeks of treatment. We had a number of secondary outcome measures. I'm not going to read these all out, but these were additional lung function measures, but also exercise capacity, health-related quality of life, change in disease severity, and also adverse event reporting. The study is up and running and is being, patients are being recruited across the 5 adult lung transplant centres in the UK. They are our trial sites. And we're aiming to recruit 90 participants who will be randomized 1-to-1 with 45 in each arm, and they'll undergo 24 weeks of follow-up. So to be eligible to be included, you have to be an adult, body weight over 30 kilos, bilateral recipient or heart-lung recipient, no single lung transplants. You have to be CLAD 1 stage 1, 2, or 3, not 4. And it has to be a new CLAD diagnosis or a prior CLAD diagnosis, but with evidence of new progressive disease. There has to be a clinician declaration that non-CLAD causes for the decline in lung function has been investigated and treated. And also all patients before entry must have been on azithromycin for more than 6 weeks and shown a continuation in their loss of lung function. So how's the structure of the study? Well, patients are screened. If they're eligible, they can be randomized in a 1-to-1 fashion. And at 12 weeks, we do an assessment of whether they've got rapid progression. If they have rapid progression and they're non-responders, they then come out the trial to access rescue treatment. If they're not a rapid progressor, they continue with the second phase of the study to get to 24 weeks. This is the regimen that we're using, 9 cycles of treatment, 9 cycles of ECP, 2 treatments in each cycle. That leaves a total of 18 treatments over the period of essentially 20 weeks. And then the primary outcome is assessed at 24 weeks. If you want to know more about the protocol, it's shown here in the publication of the protocol in BMJ Open Respiratory Research. And this is where we are. I get asked a lot of time, how's the study going? You know, how long will it be till we get an answer? So, you know, recruitment has been slow but steady, and we're on target to hit our recruitment target in sort of the spring of 2027 at the current rates here. So green is actual, and the dotted yellow line is our target recruitment. So we're not doing too badly with against our target, but we're still a little way to go. We're about 2/3 of the way to target recruitment. So the other thing I get asked a lot about is, so how does ECP work? What's the mechanism of action by which it's having its effects across these wide range of different clinical scenarios? Well, the answer is we don't fully understand the intricacies of the mechanism of action, but we have some broad, higher level understanding of that. And this is perhaps this diagram shows that working approach where essentially the treated monocytes and leukocytes, when you give them the methoxylin and then it's exposed to ultraviolet light, it binds to the DNA in the nucleus of the leukocytes. And the cross-linking that happens under exposure to ultraviolet light leads to those cells undergoing apoptosis over the next 72 hours. The cells that undergo apoptosis release a number of signals to other cells within the immune system. That's why it's so important those cells are reinfused into the patient. And those signals include potent anti-inflammatory cytokines, which leads to a reduction in pro-inflammatory cytokines, and also signals to increase T-regulatory cell activity, which, as we know, will create a more pro-tolerant environment. But to help us understand, as part of the ECLAD study, we're doing a mechanistic sub-study, and we will be collecting multiple markers of potential mechanism of action throughout the study, and I hope to be able to report back at a later date what we found and whether we could in some way predict which patients are most likely to respond to instigating ECP therapy. It would be much better if we could treat patients who we knew were more likely to respond to this type of treatment. One area we're particularly interested in Newcastle is the potential role of extracellular vesicles. And my colleague, postdoctoral scientist Rachel Crossland, won an ISHLT Foundation grant the year before last, and has been studying extracellular vesicle biology and morphology in the patient population going through the trial. And she's been using various technologies, looking at the EV surface markers, the size range of the EVs that are present, and also tracking them using nanoparticle tracking. And again, we're hoping we may be able to see some EV signals. EVs would be a very strong candidate for understanding the cell-to-cell communication that happens between those treated cells that undergo apoptosis and the rest of the immune system that is receiving the signals from those apoptotic cells. And we believe EVs may have a range in a whole range of different processes that go on in lung transplantation in terms of understanding immune cell activation, better understanding the molecular cargo, and their role in antigen presentation. And then finally, I just want to update you on another trial that we're carrying out in the UK, which has its role in personalized immunosuppression and personalized management, and that is our Sentinel Skin Flap trial. Again, funded by our National Institute for Health and Care Research. We're randomizing lung transplant recipients to standard care, i.e. without a Sentinel skin flap, or to receive a Sentinel skin flap from the same donor that they received the lungs from. The hypothesis is that this flap will act as a visual signal for the development of rejection. And as you can see here, when you develop a rash on the skin flap, that can be biopsied and graded in terms of its rejection. And we've seen some really great examples of this acting as an early warning signal for some of the patients already in the study. So there's a lot of work to still be done to recruit the adequate numbers, but another interesting way in which we may be able to personalize treatment approaches to the patient using approaches such as the sentinel skin flap. And with that, I'd like to round off and happy to take any questions or hear thoughts or comments from anyone on the call. Thank you very much.
Thank you. That was great. Any question from the audience, you can write up in the chat, and I will, or you'll speak up. Quickly, just like we have probably similar issues, mostly related to insurance coverage here in the United States for ECP. In building up this large trial in the UK, what has been, in your aspect, like the most difficult part to overcome to have all the centers get together and work on?
No, thanks for the question. The ECP was available in only one of the 5 UK centres. They had managed to secure some separate funding stream to be able to offer it to a smaller number of patients. But the other 4 centres had no access to it at all. So we realised the only way we were going to be able to access it was to try and generate the evidence ourselves. And so we had to put quite a lot of work in to come together, agree a protocol, and agree, most importantly, perhaps, was agreeing that the standard of care, what exactly that would mean across all the 5 centres, because everybody does things very slightly differently.
Yeah.
So we agreed some very strong core principles that everybody signed up to, which has worked very well. So I'm happy that the standard of care approach is there. The second then was, I guess, convincing patients that they should enter a randomized trial where only 50% of them might receive the treatment. It wasn't too difficult because, it wasn't a treatment that was going to be available outside the trial to the vast majority of people anyway. Also, we were able to negotiate with Theracos that any patient who entered the trial who was in the control arm who deteriorated could come out of the trial and access compassionate use ECP. And we were also able to negotiate that those who completed the 24 weeks of the trial, who had shown a good response to ECP in the trial, could have a further 6 months of compassionate use treatment, which has helped with recruitment and been strongly supported by our patient group. In fact, the patient group's been very vocal in promoting the study across their peers within the centres.
Another question, if you want. You showed, I think, the intriguing data coming from the group from Vienna, where they used it early on in a small group of patients, but showing very interesting results. Maybe based on some of the preliminary data that you have and on the published experience, where do you think ECP is going to go to sit? Preferably early versus late.
No, it's a great question, and I guess it may be a bit of both. But early in many ways is attractive. However, potentially expensive because you treat every patient, and you're not really sure whether that it's needed. So if you have the resources and the capacity within your ECP services to treat every patient, and some of them are challenging to treat. And actually that study, one thing I didn't mention was they only recruited COPD patients. So they were limiting it to that population because they felt they were more likely to be early extubated in the ICU and back to the ward quite quickly. Because trying to deliver ECP on the ICU on top of other support that might be required in more complex patients is challenging. So I think it was a really nice signal they got. But the practicalities of implementing that on everybody would be quite difficult. our approach to actually treat CLAD obviously has been done a lot, but what's missing is the evidence. And I think what we need to do is just start generating good quality evidence for these things, because then we've got a stronger case to get insurance companies and healthcare commissioners to fund these treatment approaches.
Could I maybe ask the those in attendance, how many of you are using ECP for some or any of your patients currently? I know we are using them we use it for patients who have private insurance for which we can get it approved. But as Lorenzo said, it's not currently approved for those on Medicare. So Mark mentioned, got a couple hands up there. Yeah.
I think when possible, right, everyone is trying to use it for CLAD. Again, with private insurance coverage.
Andy, I was wondering, thank you for the very nice talk and really cool to hear about your Sentinel study. With regards to ECP, I was wondering if you could talk about your experience with weaning ECP and sort of what, if you're using it for refractory acute rejection despite current modalities or for the treatment of CLAD. How long do you think you need that induction phase before you wean? And if you get to some graft stabilization, what's been your experience with weaning and maintenance phase or weaning completely off?
No, thanks, Jamie. Great question. And again, it's another area of a real unknown. And I guess one of the dangers is some patients start treatment and then never stop. And, I have heard of patients in some centers in Europe who've been on therapy for 10, 15 years, coming in every 6 weeks for that time for ECP. The costs associated with that will be phenomenal, and we don't have good evidence that that is required. Yet obviously sometimes people are afraid to stop in case function starts to deteriorate again. I guess one of the things we will have from the ECLAD study is some observational data that goes out longer term. We have a follow-on observational arm called ECLAD long term, which will follow these patients for 2 years. Many of the patients will stop treatment after 12 months, simply because there's no other provision to provide it. So we're going to have a sort of natural, in an observational way, see what happens to those who received 6 or 12 months of treatment, but it then stopped, as to what happens to their lung function and whether they have a further relapse. We do have the option of, if they haven't had it already, introducing total lymphoid irradiation as well, as a further rescue to those people.
Thank you.
Well, Andy, thank you so much for that presentation. I think it was very informative, and it's, treatment of CLAD is the big black box for all of us. And I think the ECLAD study is very exciting, that hopefully we can gather more information and move one step closer to, really truly helping to understand and identify therapies that may be useful for our patients. I just want to, in this last minute, a couple of things. Carly mentioned a number of the S&G documents that we have proposed, that the advanced lung failure IDN is involved with, and certainly the pulmonology professional community. A number of those are all in different stages. So some of those, like the ALAD one, is getting close to being published, but some of the others are just getting started. So if you have any interest in participating in those, I think there was a recent call put out from the S&G committee requesting people who are interested in being on the writing committees. Please reach out, respond to that, and get involved. There's enough documents to go around for everybody. Nikki put in there that deadline is tomorrow, so you have just a few hours to express your interest. But again, there's a number of documents that should allow for those who want to be involved to get involved. Again, last year we didn't really put forth any because these were proposed 2 years ago, and we had so many of them that we kind of had a little pause to get these up and going and nearing completion, or at least launched. But I think this coming year, the opportunity to propose additional documents or consensus, things like that, may come up. So please keep your eye out for any calls for ideas. And then I know we're running short on time, but if you have any ideas for symposia proposals, webinar topics, I should say symposia proposals for the annual meeting or webinar topics, please take advantage of your professional community committee. Our job is to work with you, help mold these, help kind of lift them up, if you will, and just get them to the point where we can get those accepted. So please reach out. There'll be additional calls as the next few months go on for meetings to discuss ideas, and also just kind of brainstorming activities to identify topics of interest to the community. Greg or Juliet, do you have any additional things you wanted to mention to the professional community? Anything that we forgot to put on the radar?
Nothing else to add except for our gratitude.
It really has been impressive to see the engagement from our community. You guys have been amazing. So please keep it up. You set the standard high for all of the other professional communities, and we're really proud of all the work that you've done. So with that, I'd like to thank the members of the committee, Carly and Lorenzo, for joining us, as well as Dr. Andrew Fisher for that amazing talk on personalized immunosuppression, as well as for the 20 plus members of the professional community who were able to join us live today. We look forward to seeing you all in just under, I guess, just about 2 months in Toronto. And please reach out and get engaged and stay engaged. Thanks, everyone.